My name is Cristina Alvarado. Linear IGA bullet dermatosis. Introduction. Linear IgA bullet disease in next aromi bullet disease in which built for on the skin and midges wet members. This is provoker case of characteristic fight on the red immunofluorescence for a skin biopsy in wet and eye is 8. Antibody linear can be found below the epidermis.
Hello, I'm Chika Ohata, Associate Professor in the Department of Dermatology at Kurume University School of Medicine. Our department has performed substantial research on autoimmune bullous diseases for over 15 years. I was the principal investigator for the study on linear IgA bullous dermatosis, LABD, without linear immunoglobulin deposition other than IgA at the basement membrane zone in direct immunofluorescence. We did a study because we noticed that LABD lacks common diagnostic criteria. In fact, some investigators believe that exclusive linear IgA deposition with no other immunoglobulins or complement deposition at BMZ in DIF is mandatory, whereas others believe that concurrent weak IgG deposition at BMZ in DIF can occur. However, in the latter scenario, patients may be diagnosed with bullous pemphigoid, linear IgA-IgG bullous dermatosis, or epidermolysis bullosa acquisita. Therefore, we thought it was important to study clinical manifestations and serological findings in patients with subepidermal blisters with only IgA deposition at BMZ in DIF. We retrospectively collected data for 101 patients who met these criteria and excluded patients who showed linear IgG and or IgM deposition at BMZ in DIF.
Application in your linear IgA IgH polybasis usually IgH spontaneously but can be triggered by an infection or medication. Most patients with linear IgH boiler dermatosis improves or disappear well the action within 1 word and days.
Linear IgA dermatosis and chronic bullous disease of childhood. Linear IgA disease typically occurs after puberty, with the majority of cases presenting after the age of 40. Chronic bullous disease of childhood usually presents before the age of 5. Both have a slight female predominance. Patients with linear IgA dermatosis present with pruritic, annular, or group papules, vesicles, or bulli distributed symmetrically on extensor surfaces. The clinical presentation may be indistinguishable from that of dermatitis herpetiformis. Patients may also present with lesions that appear similar to those found on bullous pemphigoid or epidermolysis bullosa acquisita. Oral and conjunctival surfaces may be involved, resembling cicatricial pemphigoid. Rarely, systemic symptoms such as fever, arthritis, arthralgias, and malaise may occur. This disorder has been associated with the intake of many drugs, including vancomycin, lithium, and diclofenac. These patients also demonstrate a small increased risk of lymphoid malignancy. In chronic bullous disease of childhood, young patients present with clustered, tense bulli, often on an inflammatory base, giving a cluster of jewels appearance. Lesions are typically located in the perineum and perioral region. New lesions may appear around the periphery of previous lesions, giving the appearance of a collarette of blisters. The sensation of pruritus or burning is common. For both disorders, blister formation is either within the lamina lucida or in the sublamina densa.
Pores accord. The newscast member are affected in almost 90% of cases. People erode appear with the bloated, beige the most affected, and the average Nielsen congenital will cause searing synecdoche and with a cancer the cornea they can cause decrease visual warfare, accurate, even blindness. You can think. Other mycoses are less frequent, such as pharynx, larynx, rectum, and esophagus.
بسم الله الرحمن الرحيم. معاكم الدكتور احمد عبد الوهاب، ماجستير الامراض الجلديه والتناسليه طب الازهر العلمي. النهارده هكلمكم عن البولس ديسوردر. اول حاجه يهمنا كلنا السورس بتاع المذاكره الاساسي. انا برشح الكتاب بتاع الدكتور احمد كامل، او بعديه يجي كتاب الدكتور عاصم فرج. وكتاب الدكتور عاصم فرج يعني ايه مستوى يمكن اكتر حتى من الدكتور احمد كامل، حاجات ازيد شويه عليه. ممكن تسمع معاهم الشرايط بتاعت الدكتور مجد الشيخ، ممتازه جدا. لو في اي حد بيجنر او اول مره يسمع جلديه، ارشح له الفيديو الموجود بتاع الدكتور ابراهيم فرج بتاع جروب كورسات اونلاين، يقدر يشوفه، يشوف البيزكس بتاعت السكين. بالنسبه لموضوع البولس، هو مقسم ل5 اجزاء، ان شاء الله هيبقى على 5 حلقات. اول جزء هيتكلم فيه عن البيزكس، تمام. البيزكس دي بتشمل تكوين اللايرز بتاعت السكين، الديزموسوم، البوينت اللي هنتكلم عنها في كل درس عشان نقدر نبني الموضوع ونفتكره مع بعض بسهوله، تمام. والاسئله اللي هي جت على ايه جزء البيزكس قبل كده في الامتحان. بعد كده بقى عندنا البنفيداس جروب، البنفيجويد جروب، دارير هيلي اند هيل جروب، الديرمولايسيس بلوزا جروب. كل حاجه عن الحاجات دي هنستفيض عنها بس بعد كده ان شاء الله. اول حاجه نتكلم عن البيزك ستراكشر بتاع السكين بوجه عام. احنا عندنا 3 طبقات للسكين، طبقه اسمها الابيديرمس، طبقه ثانيه اسمها الديرمس، طبقه ثالثه اسمها الهايبوديرمس. بشكل اساسي اهم طبقه في الموضوع البولس هي طبقه الابيديرمس، بتتكون بدورها من 4 طبقات، وفي طبقه 5 بتكون معاها في البالموس. الديرمس عندنا بيبقى السمك بتاعه بيختلف باختلاف المنطقه اللي فيها، من 400 ملم في الايليت لغايه 1.5 ملم في البالموس. هو عباره زي ما قلنا عن 4 طبقات. عندنا السترتوم بيزال،
Usually applied to Ecuador. Age 70, age 72 years old, male, the below touch blisters that affected 60% to 70% of his body surface, influence the torso, lower abdomen, and back. Are extremities the vaguely choppy subepidermal voice dermatosis with neutrophy eosinophilic consistent with idiopathy. Immunophilability, IGH, idiopathic both dermatosis.
Linear IGA bullous dermatosis. It is one of the subepidermal vesiculation, and we may see neutrophils as a main inflammatory cells. And there is sometimes a scattered eosinophils and perivascular lymphocytic infiltrate. Direct immunofluorescence will show their linear deposition, which is the most important thing here, is the linear deposition of IgA at the dermo-epidermal junction, and that is usually 80% of the time. So linear IgA is heterogeneous subepidermal vesicular disorder. In children, the disease is referred as chronic bullous dermatosis of childhood, and both disorders caused by autoantibodies against the protein 97-120 kilodalton as degradation product of bullous pemphigoid antigen 2. Classic disease results in a group of annular lesions with tense poly, it's also important, and what we call string of pearls. Drug-induced cases have been described using vancomycin. So we see here it is subepidermal vesiculation, and we see collection of neutrophil. This is a low power collection of the neutrophil, and sometimes some peripheral lymphocytes in the subepidermis and eosinophils. And when we do direct immunofluorescence, we'll be showing the linear deposition of IgA. Histologically, as you notice, that there is significant overlap with dermatitis herpetiform, but we see here it is linear by using direct immunofluorescence, so you have to do the direct immunofluorescence differentiate between them. This is a good picture for the IgA deposition.
Conclusion. Linear IgA descent affects about of all ages, but is more common in older age, where childhood IgA dermatosis is a disease of very incident is the immunization side effect community.
Hello, my name's Ian McCall. I thought what we'd do tonight is have a little look at some of the cases of linear IgA disease that are in Global Skin Atlas, and we'll also look a little bit at histopath and treatment. The thing that's important about this condition is that there are two separate age groups in which it can occur. There's this case here that occurs in childhood, called chronic bullous disease of childhood, and the more typical adult linear IgA disease. Now, we'll look at some of these images here first. This was a lady who presented with some blisters and excoriated areas on her buttocks. You can see some of the blisters still out here, these areas of excoriation. Now, she was initially diagnosed as bullous pemphigoid, and she had been treated with high-dose steroids for many years without really control. The question as to whether she had a biopsy done before, she probably had, and it was probably just an ordinary H&E biopsy, and immunofluorescence probably wasn't done, because when we saw her later, we did do another biopsy and direct immunofluorescence, and it showed IgA in a linear pattern on the basement membrane, and not the IgG and C3 that you would see in bullous pemphigoid. Let's just have a closer look. The classic feature, though, are blisters that occur on a red base, and they're usually intact blisters as well, because the separation in this condition is through the lamina lucida. So they usually will heal without scanning, but they're like bullous pemphigoid. They occur as intact thick wall blisters on a red base.